So what we'd like to do today is talk about what we call the geriatric 4Ms. And we want to describe what age-friendly healthcare is all about, and then try to convince everybody that the 4Ms, when applied consistently, help improve the quality of healthcare and lower costs for older adults. So one of the questions that comes up is why we should create age-friendly healthcare systems. We've got a lot in place now. What's so new and different about that? So one of the compelling reasons for creating age-focused healthcare is fundamentally the increase in the aging population. So we're really rapidly approaching 1 out of 5 individuals in our U.S. population will be 65 years and older. They talk about the population explosion with the baby boomers, and that is true, and that will be continuing forward. The other reason that we are interested in age-friendly is that, as you can see by this graph, is that it becomes more rectangular as time goes along. And if I don't get too dizzy looking at this thing, it basically shows you that by the time we reach 2060, that the vast majority of people will be equal over the age of 65 with those that are younger. The other reason that we want age-friendly is due to the increasing medical complexity that occurs as we age. And so we'll show you a little bit about that. And in my presentations, I like to include paintings and drawings from artists that help illustrate our points. And I'll show you a little bit later how we're trying to incorporate into that concept imagery, age-related imagery into our geriatrics education programs. So age in itself is a risk for increasing chronic conditions. So you can see this graph here that basically I would bring your attention to the 2 right-hand bars here that in middle-age groups, fully 2/3 of individuals have some form of chronic conditions. Most of it is cardiovascular disease or hypertension. But look at what happens at the very edge of the right side of the graph here, that 90% of older adults over the age of 65 have at least one chronic condition. And if you actually look at the number, the 73% that have 2 or more chronic conditions, it's evenly split into thirds between low chronic conditions, moderate, and then multiple chronic conditions. And it's that group that has multiple chronic conditions of 5 or more that really puts a real crimp on the healthcare system for a variety of reasons. So the other thing that we want to be mindful of is that there are health disparities that need and should be addressed in age-friendly healthcare. So I just happened to, this data came out of the University of North Dakota here that compares American Indian and Alaska Native populations with white populations in terms of the percent of older adults with chronic conditions. The other problem that we're facing as a healthcare system at large across the country and globally, quite honestly, is the disproportionate harm that comes to older adults, either because as a result of multiple chronic conditions, or actually things that happen to them in the hospital, for example, that we call iatrogenic disease. And certainly the 20% mortality rate that we're seeing with the COVID pandemic in 80-year-olds and older is just a vivid reminder that older adults have disproportionate harm to them in the healthcare arena. So consistent with that concept is that we know that fall rate and fall death rates are increasing. So we've had 30% in the past decade. Actually, it's been 150% over the last couple of decades, where the death rates from falls have increased. And this is despite some health interventions that we've had, such as the CDC STEADY program, Stepping On, which is a community-based program. These have all made a dent in terms of the number of falls, in terms of reducing the number of falls, but surprisingly, they have not made a dent in the death rate that occurs as a result of falls. So this is a pretty serious problem. And again, focusing our energy on age-friendly interventions is so important to try and address this public health crisis. So again, sort of this health disparities concept, I just want to bring your attention here that, that there's gender differences, just like we know that in cardiovascular disease, women typically get underdiagnosed with cardiovascular disease compared to men. We also know that falls increase with increasing age, and they further increase by increasing numbers of medications. And so if you have 5 or more medications, you have almost 100% certainty of having a fall sometime in the future. And also that there's differences between both race and ethnicity. We can see here again the disproportionate number of falls that occur amongst the American Indian and Alaskan Native population compared to other populations. And these are all important considerations when trying to address health disparities in age-friendly programs. And I emphasize this because I'm reminded of our relationship that we have at UND with some of the tribal health programs, whereby we identified a fall prevention program that we were trying to implement, only to discover that one of the tribal health programs, it took basically residents on the reservation 90 minutes to travel to see a physical therapist. So we want to try to reduce those gaps that occur in geriatric healthcare, and that's just one example of many. The other issue of disproportionate harm with older adults relates to polypharmacy. And so you can see on the left-hand column here, these poor clinical outcomes with 4.5 medications on average increases mortality rates. Falls similarly are increased with increased medications, higher level of disabilities, and finally, the concept of people progressing to frailty and disability associated with that. The other problem is medication interaction. So you have these drug-drug interactions that are almost 100% certainty as you increase the number of medications. And I haven't really, in my own clinic, done a average of the number of medications that I see of patients who are coming in, as I'm a consultant rather than primary care. But basically, my overall impression is that most patients have 10 or more medications. So you know that they have accumulated these medications and that they have a 90% certainty that there's going to be some sort of medication interaction. And so what you can see on the graph to the right is that not only is there drug-drug interaction, but there's 3 drugs that are interacting with each other, and then also 4 medications that are interacting with one another. And so when somebody comes in and says they're having gastrointestinal problems, first thing I look at is what medicines are they on, because what happens then is that somebody puts them on a medication that for loose bowels, and so they're on loperamide or some medication. Well, guess what? Somebody's just chasing the tail of the dog. They're giving them a medication to reduce side effects of another medication. So we call that the prescription cascade, and that's something that I think is important to address in age-friendly healthcare. The other problem is the current healthcare system really fails to recognize functional impairment, whether it be cognitive or physical impairments or psychosocial impairments that really are the foundation of geriatrics, or what we call older adult healthcare. So a study recently, just a couple of years ago, identified 81% of people who have some form of cognitive problems or memory disorders go unrecognized by their primary care provider. So that's just an awesome gap of recognizing what the problem is. I include here a set of drawings and paintings by this artist in the upper left-hand corner who developed early onset Alzheimer's disease. And you can see how his art deteriorated as he lost more and more of his memory. So here's Captain America. The question is, with this increase in older adult population and ever escalating vulnerabilities from disease and frailty, what is or what are the solutions to that? So I don't know if we have a superhero here or not, but we want to explore what some of those ideas might be. From my perspective, being in geriatrics, I'd say geriatric models of care are the answer. Certainly, you know, I have a bias because I became board certified in geriatrics after doing internal medicine. It's a subspecialty, and I always tell people that the geriatric boards are the hardest. It's easier to become a cardiologist than it is to pass boards for geriatrics. A lot of people don't really appreciate that when they say geriatrics is a soft specialty. But the point being is that there's not enough geriatricians around the country. In North Dakota in particular, and each state is like this, we're short approximately 40 geriatricians. South Dakota is short approximately 35 geriatricians. And so you can go from state to state and find a huge gap in the manpower for geriatric specialty services. So that leads to the right-hand arrow here, which really is to try to better train the healthcare workforce in competent geriatric healthcare. And so I've got this green arrow going in both directions to show that the collaboration between geriatricians and the healthcare workforce is really so important for moving this forward. And you can see in the paradigm on the left here that so much centers around acute care for elderly, but actually the truth be told is that most of the prevention occurs in this right upper corner of community-based healthcare, and then on the left upper corner of ambulatory-based healthcare. Because if these programs are not ramped up in addressing older adult healthcare problems, they can lead to increasing use of emergency departments, inpatient care, and just general overall acute care usage, which is costly and not good for the older adult, because what happens when they go into the hospital, they usually come out with another disability, and 40% of these people will never recover that disability. So I'd like to turn a little bit towards age-friendly health systems. You can see the logo here. This is part of the Institute for Healthcare Improvement logo. For those that don't know about Institute for Healthcare Improvement, it's actually a global operation that started 20 some years ago, and really is focused on increasing the quality of healthcare overall while decreasing the costs of healthcare. So if you apply age-friendly concepts, the idea is that you need to do so across a continuum of healthcare, starting on the left bottom here at home, leading right on through to the peak of acuity, which is the emergency room department and hospitals, and then post-hospitalization or post-acute care with descending order, leading all the way back to home, hopefully. Whereas some people are diverted off of this trajectory, maybe because of end-of-life issues related to hospice care or to skilled nursing, where 50% of the people who end up in nursing homes remain in nursing homes. So there's this whole continuum of care where you want to apply age-friendly framework or these age-friendly principles of care, again, across the continuum of healthcare. So how did age-friendly come about? It basically was, started with several foundations, American Hospital Association, Institute for Healthcare Improvement, and what they did is they analyzed all these different geriatric models of care. They brought them to the table or workshop with a variety of interprofessional experts, including geriatricians, gerontology-focused nurses, pharmacists, and social workers, and many more. And what they did is they consolidated all the evidence and say, these are the things that really work the best. I mean, geriatrics has about 72 different healthcare competencies in order to become board certified in geriatrics. Remarkably, this group said, well, for the non-geriatrician, we can consolidate these into 4 to 5 primary interventions that are going to make a huge difference in this population. So what those 4 primary elements are is at the top of what matters, assessing medication use, evaluating mentation, both for depression and cognitive impairment, delirium, and dementia. And then finally, evaluating mobility impairments or needs of the older adult. So these are all what we're going to be calling the 4 M's moving forward here. So in order to test this idea is that there was a half dozen healthcare systems across the country, some larger, some smaller, that tested through the Plan, Do, Study, Act cycle whether these geriatric 4 M's worked as a set for evaluating and managing patients in both the outpatient and acute care setting. And so they reported back after a couple of years as to what the results were. Many of these were demonstration projects. And the good news is, or the punchline is that they really did have a remarkable impact on better outcomes and lower costs for older adult healthcare. So the concept is that these geriatric 4 M's need to be practiced as a set. You can't just do depression assessment or fall assessment. They all have to be done as a set. They also, the point is that a lot of these geriatric models of care need to be adapted locally. So I'll give you an example. We were working with one healthcare system out in the western part of North Dakota, and they said, oh, we do fall evaluation by timed up and go test. And I'm an advocate of gait speed as a better parameter. I think it should be the 6th vital sign. But they said, well, everybody's familiar with timed up and go. So that's what they adopted as their 4M for testing mobility. Whereas at Sanford Fargo, we're using gait speed. So that's a good example. 2 of these timed up and go and gait speed are very similar in their risk assessments for falls. So you could pick one or the other. It's no big deal. So just going with each of these 4 M's, focusing on what matters is important because you want to understand what the patient's healthcare goals are. So frequently, it's the provider, the doctor will say, well, we need to do this. We need to give you a new hip. Well, if you're 92 years old, getting a new hip may not be such a good idea. And there might be some other alternatives. So we have to understand what the health goals are, before we start providing a list of to-dos. And then it's important to document what matters to the older adult. And this is a little bit of an issue because we've got different ways of documenting what matters. And we don't always know if they're in alignment with this item 3 with the health outcome goals. So for example, if somebody says, I want to continue traveling, and that's important to me, that's very different than somebody says, oh, I just want to be able to read a good book at home. So you can see the extreme differences between that and what levels of activity. Now, mind you, that person who reads a good book at home, we're probably going to be advocating for a little bit more physical activity so they don't have a functional decline. But the important point is that there is a range by which people feel or have their goals. And some people set their goals lower because they view aging as a disease. And we keep saying to people, these aches and pains are not a normal part of aging. And so sometimes we have to dissuade people from some of their symptoms as what they attribute to old age are in fact due to inflammatory osteoarthritis or other conditions such as polymyalgia rheumatica that happen to have gotten overlooked in the primary care clinic and were discovered in our geriatric clinic. Mentation, this is one of my favorite Michelangelo's, from the Sistine Chapel. You can see this serpent nipping into this guy's thigh. So he's obviously pretty distressed by the devil getting a hold of him. But the point being is that this just references our concept of cognitive impairment, depression, anxiety, and delirium. So when we practice the 4 M's with looking at mentation, we want to firstly use tools of assessment such as depression scales. The PHQ-2 is one tool, dementia, and looking at delirium through maybe the confusion assessment method. And then we want to have and consider both non-pharmacological as well as pharmacologic interventions to deal with these. So just as an example, sometimes people are screened positive for depression. We would like to prescribe a antidepressant such as a SSRI, serotonin reuptake inhibitor, and they said, "Oh no, I don't like medicines. I don't want any of that." And you say, "Oh well, what about an herbal medicine? Would you take St. John's wort?" And they say, "Yeah, I'd think about that." Not a bad option, because it turns out in Europe, the use of St. John's wort is actually more than using antidepressant pills, and it's equally effective. And so you've got some options that you can work with the older adult, based upon, again, their healthcare interest and goals. Getting back to what matters. So in this person, what matters to them is they don't want a lot of medications. Which leads me to medications. And so the goal here is to avoid treatment that interferes with what matters. So if you're giving somebody a medication that causes a lot of loose bowels or myalgias and muscle aches, you may not be working towards their goals. These are not acceptable handoffs or trade-offs, I should say. So the idea is that in an age-friendly healthcare system, we would like to review all the high-risk medications. And so in the United States, we use what's called the Beers list. You can Google that and actually download a pocket card that you can use for looking at medications. There's another list called the cholinergic burden, and these are medications that include things like Benadryl, which has a high cholinergic impact on older adults that can cause confusion. And believe it or not, hospitalists love Benadryl because they think it's a sedative, a hypnotic. And yeah, it'll put you to sleep, but it'll also make you goofy as a hoot owl in a certain percentage of the population because of its cholinergic effects. There's a program that came out of Ireland called the Start Stop program. And again, this is a list of different medications that are to be avoided or to be discontinued in the older adult population. So that leads us to the right-hand column of management. So firstly, to understand medications that you should avoid, that's why I gave the Benadryl example. It should be avoided. And if somebody's on Benadryl, you should try to deprescribe it unless absolutely necessary for refractory allergies of some sort, as an example. This picture shows a 91-year-old who her medication before seeing a pharmacist, and her medication burden. These are weekly numbers of pills to be taken after she saw the pharmacist. So this is a pretty effective deprescribing process that occurred here. In terms of mobility, we want people to move safely. We want to improve their function and, again, support what matters to them. So if their mobility is improved, we will have really accomplished a huge goal in maintaining that person's healthy lifespan. And it turns out, just as an aside, that there used to be so much discussion about intensity of exercise, and everybody said, well, if you do 30 minutes, 5 days a week, good enough. Well, it turns out that more is better, and we haven't proven this in the oldest old group, but longer duration of exercise and higher intensity actually reduces your cardiovascular risk enormously. So you can go from that 30-minute routine, which reduces your cardiovascular risk by 10%, which is not too bad. But if you intensify that exercise and go 60 minutes to 90 minutes, you're now reducing or have the potential to reduce your cardiovascular risk by 30% and even higher. So you can like have, cut your risk for a heart attack or stroke in half by having a more intense and longer exercise program. So as part of the 4M of mobility, what we want to do is assess fall risk, and we want to assess functional impairment. So those are two components. So fall risk, like I say, is we'll talk a little bit about what you can do for that, but these are basically things like the timed up and go test. We will use a sharpened Romberg test where you put one foot in front of the other, and if they can't hold that stance, that would indicate a fall risk. We also want to look at functional impairment. How are they doing with their activities of daily living, their instrumental activities of daily living? And if there is any level of impairment, that's the type of person that should be referred to a geriatrics program, quite honestly. And then management for mobility, some of it's preventive. So you want to reduce hospital sedentary time. Hospital sedentary time is an epidemic, and it's part of the reason why up to 40% of individuals go home from a hospitalization with a new disability. But it's also important to try to prevent falls, and then ultimately to try to increase function. And so there's a wonderful program out of the University of Chicago as an example where these older adults who are what we call pre-frail get involved in a multi-discipline, or interprofessional program in geriatrics, and they're able to reverse the course of these individuals to go from, rather than their trajectory going into frailty, they get reversed and go back to a more normal age function for that's aligned with their age group. So in terms of mobility, we want to focus on creating safe home environments. That's an important goal. We also want to identify a daily mobility goal. For my clinical practice, it's 8,000 steps a day or better. And you ask people to look at their smartphone as to how many steps they put in, and usually it's like 2,000 is a pretty good day. Well, that's not going to cut the mustard. So trying to work up to a higher level for better health is part of our process. And so that's where monitoring their progress is really important. And I just want to say that it's just not steps. So that's why I had this picture up in the right-hand corner of these resistance training. And so the minimum amount of resistance training that you need for beneficial effect in the older adult population is twice weekly. And you can see these are like, 1 or 2 pound weights here. And that's about what somebody could lift out of a acute care hospitalization. So you want to show that this is progressive, and you want to go from 1 to 2 pounds to 3 to 5 pounds, and preferably under some level of supervision to prevent injury. So as we do all of this, let's say we do all the geriatric 4Ms, we eventually want to scale it up. So we do it small, in a small fashion. And then we increase it, and spread it through the health system, clinics, community setting, maybe then also to the nursing home. So to do the scaling up, you have to practice the 4Ms together. You have to apply the 4Ms at each encounter, every patient that you see, and it has to be done on a 90% or better basis. So how do we transform healthcare into age-friendly? And the good news is that a lot of this is already in place. There's a lot of flexibility. And again, as I mentioned, there's local changes that need to be considered. So the 4M strategy is to improve the quality of care, also to increase efficiency, and ultimately to lower costs of healthcare by identifying these problems. So how do we know it works? Well, here's some recent data from Rush Medical Center in Chicago that shows that by applying these 4Ms, these are 20,000 patients, they reduce length of stay by nearly 1 full day. And this is huge. I mean, this is huge cost savings, and it gives time back to the patient, and it reduces their exposure to unsafe conditions, such as iatrogenic infections. By just simply asking what matters, you can reduce intensive care unit stays, ICU stays. You can improve the use of palliative and hospice care and really improve patient satisfaction overall. In terms of mobility, fall injuries, at least in the hospital, can amount to $13,000 or more in extra costs. It adds an extra nearly 1 week of length of stay because of fractures. And basically, if you have any type of fall prevention program, you can reduce injury and reduce costs. So these are important elements in terms of mobility program. In terms of mentation, by discovering that an individual has depression, really enables the healthcare system to address the problem straight on and try to reduce costs that otherwise are caused by unresolved depression. And for accountable care organizations, I think it's important for them to recognize the fact that the cognitively impaired patient costs twice as much as cognitively intact. And so those are just huge, huge numbers in terms of when you have a fixed amount of money to spend on a patient population. Medications, don't want to harp too much on this, but just suffice it to say that there's a lot of adverse events that occur from medications. And so when we implement age-friendly, we want to fundamentally transform how we practice medicine by using these 4 M's, but that has to go hand in hand with improved geriatrics knowledge and skills. And so what is the best evidence-based medicine for applying older adult healthcare? And that's where the age-friendly concept comes in. And for those that are associated with clinics, or even with Kara Welke, she applied for age-friendly, I believe, and with her own clinical practice, got certified as a participant in age-friendly. So just really all levels. You don't have to be a Sanford healthcare system to enroll in age-friendly. So I just want to quickly go through issues about geriatrics training. I'm a Star Trek fan, so here's Captain Picard going, says, engage when they're taking off someplace. And so we'd like you to engage in our geriatric workforce enhancement program. We affectionately call it the Dakota Geriatrics Program. And our symbol is basically representing this windy road of a journey of life heading into the setting sun that's informed by a sturdy oak tree and the lofty goals of the hawk. So this is a federally funded project. It's housed at the University of North Dakota Geriatrics Department. And basically it's a partnership with universities, healthcare systems, and community programs, much as represented by folks that are attending this meeting today. Dr. Manochas mentioned that if you enroll in our geriatrics curriculum, you can aspire to acquire a age-friendly digital badge. This basically represents a new curriculum vitae enhancement that the University of North Dakota will certify that you achieved a certain level of competency in age-friendly healthcare. We also, our program has social media for geriatrics knowledge. We're on Facebook, Instagram, and Twitter. In fact, we just launched for some of our trainees a geriatric journal club through Twitter. We also have what's called ECHO. This is a monthly, and hopefully we'll get twice monthly programs, very similar to what we're experiencing here today. Would be similar to what Project ECHO is. It's a little bit more geared towards case studies, but somewhat similar format where we have a presentation of topics, and then people will share different information. And if you can go to our Dakota website, you'll see the current schedule for talks, but they maybe you won't be surprised by the fact that all these topics center around the 4 M's of mentation, what matters, mobility, and medications. We're trying to develop telehealth and home visits program with our student trainees. We're developing, we hope, a very engaging, serious game called Jerry Pop, which is short for Jerry Population Health Game. So stay tuned for that. And we have conferences. So these are upcoming springtime and early summer conferences on age-friendly healthcare and dementia-friendly healthcare, which is a huge symposium that we are repeating from last year, different topics. But highly successful. In terms of dementia-friendly healthcare, we have multiple programs. We've been working with Memory Cafe. We're trying to expand memory cafes throughout the region. We work with senior centers to provide different topics of interest for senior health. We're trying to engage faith community nursing to really at the grassroots level bring geriatric assessment and those 4 M's to communities. And then also we're developing a curriculum for caregivers that hopefully can be delivered through various clinics and other healthcare enterprises. So just kind of want to wrap up and just say that to deliver age-friendly, and this, by the way, is not me fishing. That's something I do enjoy. The problem with this picture is that the guy actually caught a fish. I'm not so good at that. But again, just to get back to the geriatric 4 M's, is that it's practice-based, using evidence-based medicine. The idea is that we want to transform healthcare systems into age-friendly operations. And in doing so, we would like to have people partner with the Dakota Geriatric Workforce Enhancement Program for improving their geriatrics knowledge and skills. So I'd like to conclude by just saying that Thomas Paine here told us that we all have habits, thinking of thing wrong, and it gives it the superficial appearance of being right. And it raises at first a incredible outcry in defense of a custom that we're all used to, but soon everything subsides, and time will make more converts than reason will. So tincture of time is important, and I hope we apply this to our geriatric 4 M's.